Okay, well, it's 12:05. Hello and welcome, everyone. This is the UC Center Sacramento Speaker Series. This is the sixth talk of the winter quarter, continuing with our 21-22 theme of emerging from the pandemic, promoting health and prosperity for all Californians in the wake of COVID-19. So as most of you know, UCCS is a system-wide program of the University of California whose goal is to prepare California's future leaders and share knowledge to support public policy making. For undergraduates, we arrange internships and provide an integrated academic program in policy and politics. For graduate students, we provide opportunities for policy research and dissemination. And for the Capital community, we offer a number of outreach activities, such as the Speaker Series. Now on to today's topic, which is a data-driven approach to mitigate economic inequities of the pandemic. This talk is the culmination of a partnership between UC Center Sacramento and the COVID Emergency Rapid Response Pilot Project team based at UCSF. As you'll learn, this project uses mobile technology to obtain unique data on the impact of COVID on communities, and we've greatly enjoyed working with this group as our co-sponsors. Our speaker today is Mindy Durand. Dr. Durand is specialist in epidemiology and biostatistics at the UCSF School of Medicine. She has degrees from Carnegie Mellon, Stanford, and Berkeley, and somewhere in between, she was a Rhodes Scholar at Oxford. She's already led several projects funded by the American Cancer Society, by the National Institutes of Health, and now the COVID Emergency Response Program at UCOP. She's author or co-author of many highly cited publications and has made many other contributions to cancer prevention and community health. Just a word about questions. As per usual, the best way to ask your questions is to wait until the end and use the hand raising feature in Zoom. And you'll be able to ask your question and get it answered live. If that's not possible, you can certainly use the Q&A feature of Zoom to type in your question, and a member of our staff will transmit that question to our speaker. So now, without further ado, please join me in welcoming Dr. Mindy Durand. Mindy.
Thank you, Dr. Kravitz. That was a wonderful introduction. Feeling great to start off the talk. As mentioned, my name is Mindy Durand. I'd like to thank UC Center Sacramento for allowing me to introduce you to a project I have been co-leading that sought to develop a data-driven approach to mitigate health and economic inequities of the COVID-19 pandemic and recession. This project is a collaboration between UCSF, Streetwise, and the Roots Community Health Center. I'm representing our team today. Other team members are listed here. As I mentioned, I co-lead this project. The co-PI is Antwi Akom, co-founder of Streetwise and professor at San Francisco State University. As you can see, we are an interdisciplinary team of scientists and community leaders. We have a shared goal, though, of finding ways to engage in community-driven research that empowers local communities of color or low income. The project was funded by the California Breast Cancer Research Program through the UCOP COVID Emergency Funding Mechanism. Our overall intent for today's presentation is twofold: to present a novel data model for timely, contextualized understanding of structural and social determinants of health as experienced by residents in their communities, and to consider ways in which this data model could inform program and policy recommendations for those communities. The project was motivated by our understanding of the structural and social determinants of health, which impact health and quality of life. Structural determinants of health refer to the web of interconnected institutions and systems that establish and maintain privilege of the dominant group with racial, ethnic, class, and gender oppression. Social determinants of health are the environmental conditions where people live, learn, play, and work that affect health and quality of life. Social determinants can be thought of as falling into overlapping domains of influence: economic stability, the built environment, healthcare, the social context, and education. And this is a model that was adapted from Healthy People 2020. I've listed here some examples of factors relevant to each domain of the social determinants of health, the overarching concept being that the structural determinants pattern individuals' experiences and circumstances through the social determinants. This framework motivated our goal to address what were expected, to be worsening circumstances around structural and social determinants in the face of the pandemic and recession. It also emphasizes our commitment to community-driven research and response and to an equity framework, meaning that our efforts and resources would be directed towards the groups most vulnerable to adverse consequences of the pandemic and recession. Through the project, we sought to develop a data model to mitigate the impact of adverse structural and social determinants of health among communities of color and low income during and after the pandemic. We designed the data model to involve mixed methods data collection, with data forms to include resident reports, epidemiologic surveys, and geospatial data, and to involve interdisciplinary data analysis with both university and community-based researchers. And finally, to involve data integration, designing analyses and presentation of our results to highlight the potential of the mixed data types. We also wanted to look ahead and have our project support the development of tools to support communities beyond the pandemic. For example, to encourage ongoing community engagement, to monitor social determinants in real time, so to speak, and to seek additional partnerships with local, regional, and state organizations and entities to expand the development and reach of this approach. I'll start with an overview of our data model. New data collection consisted of data from the Streetwise platform, which consisted of resident-submitted neighborhood reports on resource needs, assets, and crowdsourced solutions. New data collection also included repeated epidemiologic surveys, which provided structured data on resident circumstances. We also sought to include a couple of existing data types on public resources. For this, we collected and mapped existing resources like food banks, housing assistance, and health clinics or testing sites. And we included secondary neighborhood data that is based on census and American Community Survey data and consists of census tract level information on the neighborhood built and social environment, like socioeconomic factors, counts of businesses, and the food environment. The secondary neighborhood data is maintained in what we call the California Neighborhoods Data System, started by Scarlett Lynn Gomez some years ago and currently maintained by our group at UCSF. With these data, we sought to describe the on-the-ground impact, needs, and assets for neighborhoods and individuals, to identify gaps in resources and neighborhoods in need, and establish domain-specific indicators and tracking of key social determinants. And to wrap around all of these activities, we planned for sustained community engagement, including planning, recruitment, data collection, and interpretation, priority setting, and dissemination within the community. Here I'd like to outline each data type and its impact on our study. We collected what we refer to as neighborhood reports through Streetwise. Streetwise users contributed neighborhood reports via text media to share stories and document their lived experiences and interactions with their neighborhood environments. These neighborhood reports allow us to understand personal stories and hidden resources and solutions to social challenges. We also administered a baseline survey launched in January 2021 that assesses participants' circumstances pre and post-pandemic. Participants were then eligible to complete follow-up surveys every 2 months to assess changes in circumstances over time. The surveys assessed circumstances across several domains, including sociodemographics, employment, healthcare, housing, childcare, transportation, food, well-being, and COVID-19 experiences. We also collected several forms of geospatial data. The neighborhood reports are geocoded. We collected participant residential addresses through the survey. We attempted to geocode locations of public resources, and we have the census tract level secondary neighborhood data that I mentioned on the last slide. Neighborhood geospatial data allows us to link neighborhood level characteristics to participant reports and survey responses, providing additional context. With broader participation, this would allow for generalizing results based on shared neighborhood characteristics within regions. So I'd like to follow this with this little overview with more detail and some results for newly collected data types, neighborhood reports, and the epidemiologic surveys. So neighborhood reports are generated by participants with the Streetwise platform. Streetwise is a mobile mapping and SMS platform that collects real-time data on people's lived experiences in their everyday lives. It was developed for and with communities of color or low income to foster more inclusive community-engaged research and processes. It was co-founded by co-PI of the study Antria Combe and co-investigator Hector Shaw. So how does Streetwise work as a participatory mapping tool? Guided by focus questions tailored for our study, participants indicated on the map where they had an experience they would like to share. They could rate the place or experience as a good thing, an asset, a bad thing, or a fixed thing, which refers to personal or informal solutions to barriers or challenges. They could also provide a star rating and share a qualitative text, audio, or video-based story about their experiences. In our particular story, all of those reports were text. And participants could view other community member stories and data points, creating a peer-to-peer network of knowledge during the pandemic with ongoing engagement and resource sharing. So here's what submitted experiences look like on the platform. All platform users can see the location of the report, its good, bad, fixed category, and its star rating, as well as the text, audio, or video that goes along with the report. Some mapped experiences are associated with businesses, but many others with social services, parks, and formal and informal gathering places, among other locations. Streetwise also employs successful recruitment outreach and has a network of local partners to support this outreach. We used a number of outreach modalities to assure our target participant population of residents of communities of color or low income. This included recruitment of existing Streetwise users, using recruitment flyers and postcards that were available at the Roots Community Center and other local partners, weekly social media postings, attending parenting support groups that are held regularly by the Roots Community Health Center, Spanish language materials were available, and Streetwise uses sustained interaction with its participants through text or email. As a result, for this study, we were able to recruit 70 participants who submitted a total of 236 neighborhood reports to the Streetwise platform. Excuse me. 73% of those who submitted neighborhood reports completed the baseline survey. Everyone who completed the baseline survey provided an address of residence. We did have a 50% reduction in participation with each follow-up survey. For the purposes of this project, our baseline and follow-up surveys were relatively extensive, taking 15 to 30 minutes to complete. However, towards the end of my presentation, I go into a few ideas about further improving retention, including shorter and more accessible options for administering survey questions. As I mentioned, we had around 50 participants complete baseline surveys. 75% of those participants were under 45 years of age. 87% were people of color, 73% female. 90% of our participants had less than a year of savings available in the event of a job loss, and 75% are currently receiving income support. The baseline survey assessed changes in circumstances before and after the pandemic, which in California we marked as March 2020. The employment domain asked about job losses, gains, reduction or increase in hours and pay, or working from home. The housing domain asked about a change in residence or household numbers. For food insecurity, we used validated instruments assessing food insecurity and asked participants to consider time periods before and after the pandemic, for example, in February 2020 versus at the time of the survey completion. We also asked about changes in transportation for work or personal life, whether due to changes in availability or preference. Changes in any one domain might create personal challenges, but notably, 60% of our participants reported changes in one or in more than one domain, and 35% reported changes in 3 or more domains. We also asked about several areas of well-being. 78% of people reported good, very good, or excellent physical health, and about 60% reported good, very good, or excellent mental health. As a reference, though, in California, using CHIS data, we noted that almost 89% of people in California typically report good physical health or more, and 90% usually report not having any serious psychological distress. So we think that our participant population in general has lower levels of good, very good, or excellent physical and mental health. We also asked about COVID stressors, with an instrument listing several concerns that people may have had during the pandemic, including health-related concerns, financial concerns, concerns about impact on work, family, or community, and concerns about access to goods or resources, or childcare and parenting. Out of 16 different stressors and a write-in option to choose from, participants had nearly 8 sources of COVID-related stress on average. We also presented the validated Everyday Discrimination Scale, which asks about experiences with discrimination for any reason, and the frequency of occurrence in everyday life, with options like almost every day, at least once a week, 2 times a month or year. Our participants reported on average over 200 experiences with discrimination every year. The most commonly reported reasons for discrimination were race and ethnicity, height, weight, physical appearance, gender, and age. We also asked about experiences with COVID as an indicator of the strain participants may be experiencing. 8% of our participants reported they or someone in their household was hospitalized with COVID, and 4% reported that someone in the household died with COVID. Switching over to the Streetwise neighborhood reports. Neighborhood reports were analyzed as qualitative data, the aim being to convert this robust qualitative data into quantifiable themes that emerge. You can see here our final codebook for the project, comprising 5 parent themes, each representing a group of more specific topics. A team of university and community researchers developed this codebook for themes detected in reports through a preliminary assessment and discussion. A hierarchy of these themes was created through the codebook, whereby we could determine topical categories and specific themes within each. And you see here the 5 topical categories and those specific themes underneath. Once the codebook was developed, each of the 236 reports was read and coded by 1 university and 1 community researcher to assign themes. The entire group came together in 2 sessions to discuss discrepancies in the coding and come to consensus on themes present in each report. The codebook remained fluid, and themes could be added as new ones emerged. In the end, each neighborhood report has at least 1 theme assigned, but most had multiple, and many had several themes that were assigned. This bar graph shows the proportion of reports containing each parent theme. It highlights that access to goods and resources was by far the most frequently mentioned parent theme. 82% of the 236 reports mentioned access to goods or services. From there, most frequently mentioned parent themes assigned were resources, infection control, goods, infrastructure, and well-being. Of the reports mentioning access, we can get an indication of those aspects of access more or less frequently mentioned. For example, 43% of reports assigned the access theme mentioned convenience, which we defined as the ease with which goods or services are accessed. This example excerpt about a pharmacy mentions convenience of filling prescriptions by a family caretaker. Quote, "They have implemented a delivery program for prescription medicine, making it more convenient for me and my parents." We can also see here that 1/3 of access reports mentioned quality, availability, service, or price. The well-being parent theme, while not being particularly frequently applied, it was applied to 17% of reports, was one of the more enlightening, I found. Experts assigned this category excerpts assigned to this category mentioned equity, which we defined as mentioning either discrimination or inclusion for socially or economically vulnerable individuals or groups. And coping, which we defined as reports making specific reference to places, resources, or services that help them to build or maintain resiliency in the face of the pandemic environment or other difficult situations like food or housing insecurity. This example excerpt highlights a resource or place that makes someone feel supported and included. Quote, could not recommend this place more to people part of the LGBTQI A2S+ community and supporters. I rely on this place a lot to get dinner for my family. So now that we've reviewed details of the two types of newly collected data for the study, I can introduce you to some ways we integrate the different types of data. But first, I wanted to emphasize why I think integrating different forms of data is important. Qualitative data, like the neighborhood reports, is rich and robust, full of people's experiences that can't be captured from validated survey instruments. It takes more effort to collect and convert this data to quantifiable data forms, but its richness and informativeness cannot be captured by surveys. Moreover, the use of a digital crowdsourcing platform like Streetwise has relatively wide-reaching and ongoing community engagement, which cannot be accomplished with engagement of a few individuals with one-time interviews. So analyzing these reports as I've described and integrating them with traditional surveys and geospatial data enhances the relevance and potentially the utility of each of the individual data sources alone. I'll review and show some results related to two possible ways to integrate the data types I've described. Note, though, that these are by far not exhaustive of the many ways to view the information we've collected. The first example type of integration asks, who is talking about specific topics in neighborhood reports? For example, by sociodemographic groups, by food insecurity, or by the burden of discriminatory experiences. The second type of integration asks, where are specific topics being mentioned? For example, by neighborhood socioeconomic status, or by neighborhood level food or housing insecurity. As an illustration, we can review how people are talking about access to goods and resources according to their experiences of housing circumstances pre and post-pandemic. Those who did not experience a change of residence or of housing numbers pre and post-March 2020 most frequently mentioned convenience, price, orderliness, and security in the neighborhood reports. On the other hand, those who did experience a change in housing most frequently mentioned availability of goods, quality of goods, and service quality. One more illustration of this type of integration. How are people talking about access to goods and resources according to their experiences of food insecurity? Those who were never food insecure, for example, more frequently mentioned quality of goods. Those who were newly food insecure during the pandemic, or who were food insecure both before and after the pandemic started, most frequently mentioned security in the context of access to goods and services. And here is just one illustration of where people are mentioning specific themes. The underlying blue colors here refer to neighborhood level food insecurity. So the boundaries that you see are census tract boundaries. And the colors from yellow to dark blue indicate the proportion of residents in those census tracts who report food insecurity through American Community Survey data. Quintile 1, the darkest blue, refers to census tracts in which between 3.2 to 9.1% of residents are food insecure, for example, and those that are the light yellow are those census tracts in which 20 to 40% of residents report food insecurity. The dots refer to whether participants in our study mention food resources and access in the same report. The yellow dots are those reports that don't mention food and access together. And the red dots are those that do mention food and access together. So the reports mentioning food resources with access needs or benefits seemed to occur in neighborhoods where a higher proportion of residents are food insecure. But not every neighborhood with a high proportion of food insecurity is pinpointed here as a location in which participants are commenting on or sharing experiences about accessibility of food resources. So one might conclude from this particular integration of data that those areas in which people are mentioning food and security, you can pull the specific neighborhood reports in which in which food and access are being mentioned in these particular locations, for example, in the Emeryville area of Oakland, and see what those reports are sharing about. Is it a specific resource or a specific access need or benefit? So we think that the data model that we've presented is capable of adapting to trends and needs over time. Excuse me. The data itself can be continually adapted to highlight needs for services and resources. So focus questions that residents are given to respond to in the Streetwise platform can be changed over time. Survey questions, of course, can be adapted to particular needs of outreach and can be pinpointed to specific domains, for example, housing or food. So in terms of why we need to adapt to trends and needs over time, doing so would improve implementation of policies and services over time, would sustain community engagement and community input on processes and service provision, and provide evidence for improvements to circumstances around social determinants of health. So how would we do this? There could be periodic analyses of resident reports. There could be repeated survey questions and template data presentation schemes to assess trends over time. So how do we convert the intent in this project to action? As mentioned, we wanted today to present a novel data model that we thought would be useful for timely and contextualized understanding of structural and social determinants of health as experienced by residents in their communities. We think strengths of this data model include domain-specific data collection. In our particular project, we collected data across several domains in order to have a broad assessment of people's circumstances, but incorporation of this data model into other projects could include, like I mentioned, assessment on particular domains like employment, housing, or food. Data collection can be hyper-local, so you can involve residents within one specific community, or it could be regional. You can involve residents in, for example, the Greater Bay Area or the Fresno area, and you, excuse me, in order to get a broader sense of people's circumstances. And then that neighborhood secondary level data can be used to generalize those experiences within the region. And this is, we think another benefit is that sustained integrated data collection addresses the ongoing need and is poised to aid response to future crises. Some considerations for the data model, though. Ease of participation. So because we wanted to take a broad approach with our project to consider the applicability of our data model, but the survey and the reports could be focused on particular domains, making those surveys shorter to improve retention as well. And also surveys could be delivered via text or text notifications at regular intervals as opposed to the longer online surveys that we incorporated. Urgency of response. So there must be, in consideration of the application of this data model, it's important to consider the urgency of the response. And so doing so would require residents to submit reports on a shorter time interval and would require response to surveys in shorter time intervals if there's an urgency in response that's needed. Also timeline. You would want the overlapping of Streetwise support submission with survey use in order to assure the greatest utility of that data integration. And also participant, partner, and researcher support needs to be considered. So this data model does require support for participants to keep them involved, support for community partners who help with outreach and retention, and to analyze the qualitative reports and be a part of that interdisciplinary research team, and also support for researchers to guide the incorporation of the data model into projects. And so our second intention was to consider ways in which this data model could inform program and policy recommendations. We think it could be applied to specific resource needs, for example, eviction moratoriums around housing needs, food resource infrastructure, and childcare needs. We think that it can be used to help identify gaps in existing resources or improvements to existing resources. And we think that it can be used to assess the quality and reach of resources. So I wanted to introduce again the members of our study team. Dr. Abueleta with Roots Community Health Center is the Roots co-founder and CEO who approved the project and Roots involvement in the project. Jamaica Salwell was the co-investigator on the project and program director of many of the Roots programs that we plugged into for our recruitment strategies. Yasmin Griffiths and Lupita Gonzalez were community researchers who helped to analyze the Streetwise reports. As mentioned, Dr. Akam was co- and principal investigator of the project and is co-founder of Streetwise. Ekta Shah was a co-investigator as well and is also co-founder of Streetwise. Tessa Cruz is the Streetwise data collection manager and directed much of the Streetwise outreach and retention. And Brenda Matias is a graduate student at Berkeley who did some outreach coordination as well. Alice Guan is a graduate student researcher at UCSF who did much of the data analysis and collection and organization of collection of the data management. Salma Sharif Marco is a co-investigator at UCSF who advised on some of the qualitative data collection and analysis for the project. Catherine Lin is the GIS analyst who geocoded our data and created the maps that you see. And Debbie O is a data scientist at UCSF with specialty in data visualizations who helped to create some of the flyers, outreach flyers that we use for the project. So I have here my contact information. I can be reached by email or through Twitter with any questions that we're not able to address in the seminar here today.
Well, thank you so much, Dr. Derome, for just a fantastic talk today. And so with that, I'm going to give Brooke here just a minute to go ahead and stop the recording.